Today, I will discuss about the deficiencies of the complement system. The complement system refers to a group of plasma proteins called the complement proteins, which are produced in the liver and act collectively to help destroy pathogens. Think of them like a little militia that complement the work of antibodies. The complement system is part of the immune system, whose major function is to protect the host from infections. In the defense, both the innate and the adaptive immune systems are operative through several mechanisms. The complement system comprises an important part of the innate defense, and some act bridging innate and adaptive immunity. The importance of complement in defense against bacterial infections has become clear, with some role in against fungal and parasitic infection. The ability of mannose binding lectin bind to HIV has been shown in the in vitro study. With complement deficiency, there is a deficiency in one or more of the complement proteins, which are part of the immune system. Complement deficiencies can either be acquired or inherited, and often result in a weaker immune response to infections. The complement system helps with three important immune processes: inflammation, phagocytosis, and the creation of membrane attack complexes or MACs. Inflammation is when chemicals and cells collect to protect a damaged or infected area. Phagocytosis is when certain white blood cells called phagocytes engulf and digest antigens, and membrane attack complexes are structures which dig into antigen surfaces and lyse them or rupture and kill them. Let's now discuss complement deficiency. Complement deficiencies are considered to be rare disorders and comprise between 1 to 10% of all cases of primary immunodeficiency. Complement deficiency is also known as hypocomplementemia. Complement deficiencies are rare. They include isolated deficiencies of complement components or inhibitors and may be hereditary or acquired. Hereditary deficiencies are autosomal recessive except for deficiencies of C1 inhibitor, which is autosomal dominant, and properdin, which is X-linked. Deficiencies in any component of the complement system can lead to immunocompromise and overwhelming infection and sepsis. The deficiencies result in defective opsonization, phagocytosis, and lysis of pathogens, and ineffective clearance of antigen-antibody complexes. Complement deficiency are poorly characterized clinically and have been difficult to detect, so they will be likely to be significantly underdiagnosed. Etiology. Most complement deficiencies are caused by a genetic defect in one of the genes that code for the various complement proteins. No clear environmental or drug-related causes have been identified. Role of complement in disease. The complement system plays a critical role in inflammation and defense against some bacterial infections. Complement may also be activated during reactions against incompatible blood transfusions and during the damaging immune responses that accompany autoimmune disease. Deficiencies of individual complement components or inhibitors of the system can lead to a variety of diseases, which gives some indication of their role in protection against disease. Now, let's move to the pathophysiology of the complement deficiencies. The complement cascade consists of 3 separate pathways that converge in a final common pathway. The pathways include the classical pathway, the alternative pathway, and the lectin pathway. The classical pathway is triggered by interaction of the Fc portion of an antibody or C-reactive protein with C1q. The alternative pathway is activated in an antibody-independent manner. Lectins activate the lectin pathway in a manner similar to the antibody interaction with complement in the classical pathway. So these 3 pathways converge at the component C3. Although each branch is triggered differently, the common goal is to deposit clusters of C3b on a target. This deposition provides for the assembly of the membrane attack complex, components C5b9. The MAC exerts powerful killing activity by creating perforations in cellular membranes. Deficiencies in complement predispose patients to infection via 2 mechanisms. First is ineffective opsonization, and second, defects in lytic activity. Specific complement deficiencies are also associated with an increased risk of developing autoimmune diseases such as systemic lupus erythematosus. An intricate system regulates complement activity. The important components of this system are various cell membrane associated proteins such as complement receptor 1, complement receptor 2, and decay accelerating factor. In addition, these cell surface associated proteins, other plasma proteins, regulate specific steps of the classic or alternative pathway. For example, the proteins factor H and factor I inhibit the formation of the enzyme C3 convertase of the alternative pathway. Similarly, the enzyme C1q esterase acts as an inhibitor of the classic pathway serine proteases C1r and C1s. Deficiency of any of these regulatory proteins results in a state of overactivation of the complement system with damaging inflammatory effects. 2 clinical manifestations of such deficiencies are paroxysmal nocturnal hemoglobinuria and hereditary angioedema. How do complement fights infections? As part of the innate immune system, complement acts immediately to start the process of removal and resolution of the problem. The complement works with the inflammatory cells of the innate immune system and those of adaptive or acquired immunity. Complement proteins in the circulation are not activated until triggered by an encounter with a bacterial cell, a virus, an immune complex, damaged tissue, or other substance not usually present in the body. Clinical manifestations. The following symptoms are consistent with complement deficiency in general. Recurrent infections. Depending on the kind of complement deficiency, patients can present with viral infections including herpes simplex and influenza A, as well as pneumonia, ear infections, colds, meningococcal disease, and sepsis. Autoimmune diseases. The most common autoimmune disease associated with this disorder is systemic lupus erythematosus. Renal diseases. This can include glomerulonephritis and atypical hemolytic uremic syndrome, angioedema, vasculitis, age-related macular degeneration, antiphospholipid antibody syndrome, paroxysmal nocturnal hemoglobinuria, joint problems, dermatomyositis, lung function or MBL variant alleles, and anaphylactoid purpura. Diagnosis. So how is a complement deficiency diagnosed? Complement deficiencies are commonly diagnosed with the following tests: total serum class hemolytic complement test, alternative hemolytic complement test, screening for immune complex diseases, antinuclear serology to test for lupus, urinalysis, and complete blood count. Treatment modalities. There are no specific treatments available as yet for the complement deficiencies, but the following treatment can include prevention and treatment of infections, including the use of antibiotics, use of fresh, frozen plasma to bolster immunity, immunization against Neisseria meningitidis for boys with Properdin deficiency, and also the immunosuppressive therapy. Medical management. Definitive treatment of complement deficiencies requires replacing the missing component of the cascade, either through direct infusion of the protein or through gene therapy. Because neither of these options is currently available, treatment of these patients focuses on managing the sequelae of the particular complement deficiencies. For many patients, treatment must be focused on eradicating a particular infection, especially with encapsulated organisms such as N. meningitidis. In most cases of the meningococcal disease, treatment with meningeal doses of a third-generation cephalosporin covers most strains of N. meningitidis. Let's move to the risk factors and complications of complement deficiencies. Complications: death due to overwhelming infection, central nervous system damage due to recurrent meningitis, respiratory tract damage due to recurrent infection, unusual or occult infections, and organ damage due to circulating immune complexes. Example for this is the chronic kidney disease. Risk factors: family history, race. Caucasians are at greater risk for Properdin and C2 deficiencies, while those of African descent are at greater risk for C6 deficiencies, and those of Asian descent for C8 and C9 deficiencies. Age. Some forms of complement deficiency will present within the first months to first years of life. Others will present in later childhood or adolescence. Sex. Most complement deficiencies affect both sexes equally, but Properdin deficiency, for instance, is X-linked and presents only in males. Nursing diagnosis. Impaired skin integrity related to use of immunosuppressant drugs as evidenced by skin rash. The following nursing interventions are: instruct patient to wear protective eyewear, wear a wide-brimmed hat and carry an umbrella, wear maximum protection sunscreen SPF 15 or above in the sun. Sunbathing is contraindicated. Inform the client of the availability of special makeup to cover rashes, especially facial rashes. Encourage adequate nutrition and hydration. Acute pain related to inflammation associated with increased disease activity as evidenced by facial grimace. The nursing interventions are the following. Encourage the client to assume an anatomically correct position with all joints. Suggest that the client uses a small flat pillow under the head and not to use pillow to prop the knee. Encourage the client to perform range of motion exercises after the shower or bath, 2 repetitions per joint. Encourage the use of non-pharmacological measures of pain control such as relaxation, distraction, or guided imagery. Fatigue related to anemia as evidenced by lack of energy and tiredness. The nursing interventions are the following. Determine whether fatigue is related to psychological factors. Encourage the client to sleep in an anatomically correct position and not to prop up affected joints. Encourage the use of progressive muscle relaxation techniques. Encourage the client to frequently change position at night. Prognosis. C3 deficiency can lead to recurrent infections with severe sequelae and high morbidity and mortality. There may be overwhelming sepsis in early life. Deficiencies of the components of the MAC C5 to C9 tend to lead to less severe infections and have a better prognosis with careful management. People with a classical pathway deficiency are at higher risk for developing autoimmune disease but have a lower risk for overwhelming sepsis.